Modern health policy relies on a simple assumption: the patient pathway. We assume a direct, linear journey from a person's home to a clinic. To handle more patients, we simply build more clinics, add more beds, and expand medical capacity. Yet, as clinical capacity grows, preventative health outcomes for specific demographics are stalling. For adult men, the numbers reveal a clear disconnect between availability and engagement. A recent gov.uk survey examined male healthcare utilization over a comprehensive 3-year window. This utilization funnel shows that 54 policymakers treat these as isolated issues. Hospital administrators manage medical avoidance, and urban planners manage failing squares. We are seeing a simultaneous failure in both systems. The clinical pathway is blocked by psychological friction, while the civic pathway is blocked by physical decay. Solving this medical utilization crisis requires a different approach to urban planning. We have to re-engineer public spaces to deliver gender-responsive health interventions directly into the community. We cannot construct our way out of a public health crisis using only hospitals. The true preventative battlefield is the public square. When patients don't show up, administrators usually blame logistics. The assumption is that long wait times or a lack of local services keep people away. The gov.uk data confirms that waiting lists account for 43% of avoidance. However, behavioral choices actually dominate the failure matrix. This chart shows internal rationalizations. 37% were avoiding dealing with the issue, and 29% felt it didn't require medical attention. Together, these normative and psychological barriers form a massive psychological bottleneck that physical clinics cannot fix. Voluntarily entering a clinical setting requires crossing a vulnerability threshold. A patient has to admit they need help and then step into an intimidating, high-stigma environment. For men with low health literacy, particularly regarding mental or sexual health, this vulnerability threshold is exponentially higher. The less you understand the symptoms, the harder it is to ask for help. Traditional awareness campaigns fail to reach these demographics. Billboards and pamphlets still require the individual to process the information and cross that clinical threshold completely alone. When early-stage psychological barriers are ignored, men do not seek care until their symptoms become unbearable. By the time they finally present to a doctor, their condition has deteriorated, placing an immense financial strain on acute emergency care systems. Asking a socially isolated demographic to voluntarily navigate an alienating clinical environment is a structural failure of the healthcare system, not a moral failure of the patient. To understand why these men are isolated, we have to look at the built environment. Sociologists rely on the concept of the third place, the critical, accessible social infrastructure of a city that exists entirely outside of home and work. According to the Project for Public Spaces survey, these third places are disappearing, strangled by heavy bureaucracy and crumbling under aging infrastructure. Cities fall into a strict funding trap. They allocate millions in capital to construct new parks or plazas, but they provide zero operational budget for the programming, maintenance, and community management required to keep them active. This flowchart tracks the consequences of that disinvestment. It triggers a cycle known as the human doom loop. Without active programming, spaces decay. People retreat indoors, leading to deep social isolation, which causes further civic degradation. This loss of civic life directly degrades physical health, driving an epidemic of loneliness. To understand the physiological threat of this isolation, we look to the highest medical authority in the United States, Surgeon General Vivek Murthy. The Surgeon General has established a specific, measurable health equivalence. Severe social isolation damages the human body to the exact same degree as smoking 15 cigarettes a day. Without accessible, programmed public spaces, men lose the peer networks and casual daily interactions required to combat this isolation. We spend millions treating downstream cardiovascular disease and depression, while starving the minimal maintenance budgets for the public spaces that could prevent the isolation causing those conditions. A broken public square acts as a primary vector for the disease of isolation. To reach isolated demographics, we must utilize gender-responsive spatial interventions. These are environments designed specifically to bypass demographic stigma and lower the vulnerability threshold. The most empirically validated solution to both the UK healthcare avoidance data and the civic failure data is the men's shed model. These spaces are structured around practical activity, fully equipped woodworking shops, active metalworking garages, and community gardens. There are no waiting rooms, no clinical clipboards, and no sterile white walls. This architecture forces a psychological mechanism called parallel communication. Working shoulder to shoulder on a physical task bypasses the vulnerability of clinical therapy. Academic studies show these participants experience delayed cognitive decline, massive reductions in isolation, and significantly higher prostate health awareness. Building a birdhouse or fixing a lawnmower acts as a Trojan horse. The activity delivers high-value health literacy into the community without triggering the psychological avoidance of a clinic. In these environments, the exchange of chronic disease management strategies and mental health support happens naturally, peer-to-peer, over the noise of a lathe. Yet, despite the proven efficacy, current data shows that only 10% of men are engaging in these specialized interventions. For the 10% who do engage, the environment explicitly restores their sense of autonomy, competence, and purpose, the exact psychological elements stripped away by a hospital waiting room. A shared workbench achieves what a clinical waiting room cannot. It delivers a preventative medical intervention disguised as autonomous, communal purpose. We currently rely on an isolated clinical outreach model that fails to reach vulnerable populations. The alternative is an integrated community hub model that naturally pulls those populations in. The Project for Public Spaces survey warns that we are actively blocking this alternative. Complex zoning laws and bureaucratic red tape prevent communities from legally establishing and maintaining these activated spaces. Rigidly separated municipal budgets create a fiscal paradox. Health departments are starved for preventative solutions, while parks departments fail for lack of operational funding. The structural solution requires tearing down those silos. Funding the operations, maintenance, and programming of public spaces must be officially classified as a direct healthcare investment. Catching chronic cardiovascular issues or severe depression in a civic space months before a crisis saves the immense cost of acute clinical care. This requires a shift in urban planning. We have to stop building passive infrastructure and start engineering active, programmed network nodes. Health policymakers must mandate cross-departmental funding initiatives that aggressively move preventative budgets out of hospitals and into community infrastructure. Urban planners must design spaces explicitly tailored to bypass the normative barriers of highly isolated demographic groups. Continuing to treat public space as a discretionary arts and culture luxury is an outdated, mathematically flawed approach to public health. Rebuilding the public square as a deliberate, data-driven engine for social connection is the new priority for preventative medicine.